We're ready if you want.
Hi, everybody. Thanks for joining. Mikhail Bedell, stepping in as chair today. Our chairperson is not feeling well. This is the Lewis and Clark City County Board meeting for February 22nd, 2024. Call the meeting to order. Hopefully everybody's had a chance to review the agenda. Any changes?
Mr. Chair, just one change under board discussion. We'll need to postpone the suicide prevention presentation to another month.
Okay, thank you. Any other changes to the agenda? We'll move to the minutes. If anybody hasn't had time to review the minutes from the January 25th meeting, they can do so now. And does anybody have any comments or changes, corrections to the minutes from January 25th? Not hearing or seeing any, we'll accept the minutes. I don't believe we have a quorum at this point, right? We've got we've got four of us. Four. So we will move down to the board discussion and begin with a variance summary. Is Beth with us? I don't see her.
I do not have any of the staff on as of now, except for Sarah.
Yeah,
Oh, they're probably gonna join
yeah, a little.
later.
Oh, sure. Thinking that it's.
Well, if there's no opposition,
I can send an email now to staff.
okay.
Yeah, just have them jump on and, well, I can do my reaccreditation update.
Sure.
And then we can
Yep.
do the training item.
Okay,
And then
that'd be fine.
we'll just jumble the agenda all up today. How does that
Sounds
sound?
perfect. Yeah.
Okay.
Flexible.
Light on our toes today. So, Mr. Chair, members of the board, the reaccreditation update item on the board, under board discussion. We have now completed the process all the way up to the site visit. And so what that's looked like up to this point, back last year, we had a deadline of submitting all of the documentation to show evidence that we meet the standards and measures of public health accreditation. The accreditation board then reviewed all of those documents, and through that review process, they flagged a few of them and essentially reopened 44 items is what they reopened, which was actually not bad because the amount of documents that we submitted was well over 200, probably closer to 300 documents total that we submitted. So 44 were reopened. They gave us a very short window to readdress them. So we did go through each of those 44 items and address their questions, or we gave them a different example. And then once that deadline hit, the accreditation board then took time to review again. And so now they're in the process of scheduling and planning for our site visit, which is scheduled April 10th and 11th. So that site visit will be virtual. For those of you that, I'm not sure if anybody was around when we were accredited the first time 6 years ago. It was just.
I think it just came on, and I was there.
Yeah.
Yeah.
The site visitors came on site and they spent a couple days with us face to face, which was really nice to have them here. This time around, it will all be done virtually, and it will be scheduled over the course of those 2 days. On the morning of April 11th is when the site visitors would like to visit with our governing board, which is you all. So if you could plan for April 11th at 9 a.m. tentatively, I'm still waiting for the confirmation and the final agenda to come from our site visitors. Jolene can also send a placeholder for you all to get it on your calendars. But be flexible because I'm not sure if that's exactly when. But what the site visitors said is they try to schedule the Board of Health or the governing body first thing on the second day. So I'm hoping that 9 o'clock will hit the mark. So that-
Some things.
and to anticipate about an hour. And so this is the site visitors' opportunity really just to hear from the Board of Health. If they have any other materials like prep materials for you all in advance of the site visit, I will absolutely make sure that those get forwarded on to you so that you have an idea of what might be coming. But last time it was more it was conversational. So I'm hoping that this will be conversational as well. Probably want to hear your perspective on the role that the board plays in the governance of the health department. So that is the update on reaccreditation. Do you have any questions for me?
I was wondering of the items that they brought up, was there anything that was kind of a big surprise?
No, it was definitely a challenge because some of the feedback, we didn't get a lot of feedback. So the feedback was essentially either fix it or find a different example, but they didn't say
How to do it?
or they didn't say what about the example that we gave them didn't hit the mark.
Hmm.
So we essentially just had to go back to the standards and measures and look at it again and see if we missed something in there or, review it again and see if we can adapt the example to meet it better, or if we just needed to give them something different to meet it. So that was probably the most challenging part, was not knowing quite what they didn't see in the example that we gave them.
When they were on site, was there a little more feedback than kind of
Yeah.
this?
So the
this one?
first time around, it was a very similar experience where we submitted everything, they reviewed it, they opened certain measures. And I honestly don't remember what level of detail when they reopened them I don't remember the level of detail for the feedback that they gave us. But we were able to address their concerns and we were accredited. My sense is we were able to address their concerns and we won't have any issues at this point. So, yeah. Yeah. My guess is that during the site visit, they may ask about those items again so that it's dialogue rather than just documents that are uploaded to a system. So when you can put some color commentary around an example, it may help them understand what it is that we were accomplishing with the example. So yeah, very challenging. Yeah, and time consuming. So I'm glad that this is almost over. It's a long process.
Any other questions for Drenda regarding the reaccreditation? All right, thanks.
And that Beth is on, so if she's ready, we can circle back to the variance summary.
Welcome, Beth.
Hi there, you guys. I apologize. My laptop said I needed to update Zoom and would not let me just do the browser. So anyway, I grabbed my iPad and now I think I'm on here. So again, this is Beth Norberg. I'm with Environmental Division, the Environmental Division Program Supervisor, and I am here to talk to you guys today about variances. Every year we do an annual review of our variances, and I don't know, I think with my iPad, I don't know if there's an option to share my screen. So I'm just going to go through in your board packet on page 10, starts the presentation that I had here. So if it's okay with you, I would like to maybe just do it that way because I'm not seeing a way I can share my screen here. I've never done Zoom on my iPad before, but unless Drenda, you have a suggestion, I don't think.
No, I think that'll
That's
work. Yeah, no
Perfect.
worries. That'll
Okay.
work.
Yeah, thank you. So I promise I'm prepared, but that threw me a little bit. So real quick, so going through the slides, this is an annual review. So what we like to do with the Board of Health is every year look at our variances, describe kind of what a variance is, you know, why do you guys even should care about them, why you do care about them, what do they mean to you as a Board of Health? They are pretty significant when we're talking about land use and growth in Lewis and Clark County, particularly right now. And so it is important that you guys kind of understand what they are. And when you have this variance request go before you, kind of get an idea and go, wait, I heard Beth talk about this one day. And you know, what that means for you guys. So in Title 50, which is where boards of health get their authority, that is where the state has mandated that boards of health take for adoption to their local governing body regulations for the disposal of sewage from public and private buildings. And that is Title 50, that's in your authority. And so it's really important because it does say that it must, the regulations, those regulations that we have to adopt, have to describe standards for granting variances from requirements. So, and that they also must provide for an appeal process. So we can't just deny or approve variances, but not give people an option for appeal. So, what is a variance? I'm going to skip around a little bit because I actually didn't like the way these were in the way I first did the slides. But what is a variance? So you're saying, what do you mean? What we have standards, we have them in under Title 50. What does that mean? A variance is an exception from the minimum requirements. So as a sanitarian, as staff, I can't just go to a site, do a test hole, tell the property owner, you know, kind of doesn't really meet the requirements, but don't worry about it. Just put that septic system in the ground. No big deal. I won't tell anybody. We can't do that. That's not what we do as sanitarians. However, if something doesn't meet the minimum requirements for a septic system, then we could say, you know, there is a process for potentially going to our Board of Health and asking for a variance from the regulation. So a classic example that we see a lot is floodplains, depth to groundwater. You know, there's various setbacks that can't be met when you're putting in a septic system or you're replacing an old septic system. So as staff, we go through that process with that property owner and tell them, you know, you can technically apply for this variance and the Board of Health has that authority to grant that variance from the regulation. So what are those regulations? They are our local Lewis and Clark County on-site wastewater treatment regulations. And those regulations come from the state minimum standards. We affectionately call them the 900 rules. They're the administrative rules 1736-900. So if you look at those 900 rules in the administrative rule, you also will, when you read them, you go, gosh, those look a lot like our on-site wastewater treatment regulations. And that's because we have to, at a minimum, carry those over and plop them into our regulations, and they cannot be less stringent than the state minimum. So we cannot, in Lewis and Clark County or any county in the state of Montana, have a regulation for septic systems that is less stringent than the state minimum standard. But there's also what varies a little bit with regulations is we might have an enforcement process that's a little bit different than, say, Missoula County. We have a certified installers program that say is a little bit different than what they do in Broadwater County. So we have a few nuances to our local regulations, and it's because there's no comparable standard in the state administrative rule. So we're allowed to adopt some of those different regulations, like enforcement and certified installers are kind of the two main ones. So those, our regulations really do come from those 900 rules in the administrative rule. And then the circular DEQ 4 is our design standards. It's how you put a trench in the ground. It's the type of concrete you have to use in a septic tank. They're the design standards for the type of septic system. So an applicant, if they don't meet any of those, the Lewis and Clark County regulations, the administrative rules, 900 rules, or the circular 4, they can request a variance. That is something the Board of Health can grant or deny. So we work with a property owner to first, yep, absolutely, like you would definitely need a variance for this. And this is your process, and kind of walk them through that. So this is a quasi-judicial action. It's formal, informal, but it definitely has some requirements. and it's a procedure to objectively determine the facts and draw conclusions. So again, we can't be or the board cannot be willy-nilly about how they approve or deny a variance. They have very specific criteria, and those are laid out in our wastewater treatment regulations and the administrative rules. And also with that is how to appeal if they don't like the decision. Let's see. So why do we then have to look at this every year? It's a system, it's in place. Why do we need to revisit? Why does Beth have to come every year and talk to you about variances? Big thing is evaluating trends. We want to look at, are our regulations, how are they looking? Our local regulations, if there's been changes in the state regulations, we need to look at some of these trends. Are we seeing a ton of variances? For why? Like, why are we seeing so many? How can we adjust that? What can we do within the realm of the law to fix that? Are we appropriately allowing, denying, granting, or denying variances? Oh, is everyone still there?
Yep,
Yeah.
we're here.
Okay, cool.
Yeah.
Are we appropriately granting or denying variances? That's something that we've been talking with legal lately about. Is our process still within the realm of what we should be doing? It offers opportunities for collaboration. So say someone comes in with a 100-lot subdivision and the planning department is working through that, but say it is adjacent to a floodplain, and maybe down the road FEMA might change those floodplain boundaries. How is that going to affect us with all of those septic systems? So we can collaborate with the planning department on what maybe, looking at different options for wastewater treatment or water supply. So it just allows us to kind of look at everything and see where everything's happening. And then also to evaluate our regulations, which I just talked about previously, is, do we need to make any changes? I know I just spoke with Flathead County, a Board of Health member and a person in their environmental division last month. They're really struggling with their growth and kind of feeling like they're arbitrarily granting variances. People are asking for variances with new development, and they're feeling like, gosh, should we be granting this? Is this really protective of public health? Or are we being anti-land use or anti-development? They're really trying to find a balance right now on how they should be granting those variances. If you do look at the variance criteria, they're a little vague for a reason. And it's because it allows each Board of Health, each county, to somewhat be able to be the owners of those criteria and make determinations on whether or not they should grant a variance specific to their county and their specific circumstances. There's land or our land features here in Lewis and Clark County are very different from somewhere in eastern Montana, where they don't have high groundwater. They have tons of really good soil and lots of room. They don't have mountains and slope and all of those things. So we really want it. That's why we also, obviously review these and look at this constantly to make sure you guys are able to make good decisions as a board. So there is a chart in your packet on page 12, and it's a line chart. It's the orange line, the top line is our permits that have been issued since this is 1991, to clear through to calendar year 2023. And then our bottom line is our variances that were granted for those same years. And for the most part, and this is why when we're looking at an annual review, we're looking at have our permits skyrocketed, and so have our variances. That kind of will tell us, wait, do we need to do something with our regulations? Why are so many people asking for variances? Or are our permits really dropped, but our variances are going up? We can kind of look at the reasons for that. You'll see with this chart, there were a few spikes. The first spike, I believe that was 1993 or 1994, I believe. But that was when the Water Quality Act came into play when it comes to non-degradation for septic systems. And it was a big rule change. And there were a lot of variances to catch up to that. There was a significant rule change at the state when it came to non-degradation and also to some other things. And so we saw an increase in variances. And they issued that year almost 400 permits. That's a lot of permits. And there was kind of a little bit of an economic boom at that point. And then, of course, we went through that. You can see that these lines usually, as permits kind of fall or rise, so do the variances. In 2000, I want to say it was 2007, we had 21 variances that was related which is a little different. This was unique. We had a lot of variances because in the town of Remini is the upper 10-mile Superfund site. And we had to replace, or EPA went in and replaced all those septic systems in the town site, brought them up to standard, got them all off these old septic systems. That was part of the cleanup efforts in the upper 10-mile. And those didn't meet regulations because there's a high groundwater table and floodplain that runs through that area. So we did a lot of variances for the town of Remini. So that was kind of that secondary peak, but it does show that even something like a Superfund site or something might influence how we have to decide site factors for a septic system. But for the most part, I think what I want to say generally right now, last year we issued 261 permits. We only did 4 variance requests. I don't know if we're doing something wrong. No, the staff is not catching something. No, I'm kidding. But it's good. I think we're at a point where, from a review standpoint, the year before we did 7 variances and then 6 and then 7. We're kind of in that 5 to 10 range for variances and roughly 240 to 260 permits issued. It's a good spot we're in. And so as staff, we recommend obviously to the board that, I don't believe there's any drastic change that needs to happen with our variance process or procedures. We are going to be opening up our regulations this year, hopefully at some point this year. Looking at rules, making sure we're still matched up with the state. We should be, but fixing anything like that too, so that we aren't requiring people to being applying for frivolous variances or variances that may not be necessary. But I think we're in a good point right now. So it's kind of like last year. Last year, the trend was about the same. There's really no changes that should be made to our variance. 2 variances at all, except for we'll work with legal on some of our more nuanced ones and how we want to handle those to make sure we're doing this correctly. But with that, I think that was roughly it. If anyone has any questions, I'm certainly open to answering them.
Does anybody have any questions for Beth?
Mr. Chair, if I may just add one more piece of information that as a reminder to the board, and you all experience this already anyway when you have a variance come before you, but the process allows for the hearings officer, which right now is Lisa, is your hearings officer, to either hear the variance outside of a board meeting, or she can say, I think this needs to go to the full board. And then you all would hear the full variance. Typically what happens is that she'll do it in a hearing outside of the board meeting and then bring you a recommendation. But Beth always recommends that we take a variance to the full board just so that you all have the experience and understanding of what that the A to Z process looks like. But there are a couple of options as far as the board hearing a variance.
Yeah, thank you. Yes, that was also, we're a little different in Lewis and Clark County. We have a hearings officer process. I think there's other counties that are jealous of that a little bit. I think Gallatin County does close to like 40 variances a month with their board. So I guess we're lucky here. But they definitely need to probably review their processes. But yes, the hearings officer, and that's been a great option, but we definitely will bring a variance or 2 to you guys for review, just so you have an idea of how it goes.
Great, thank you. And thanks, Lisa, for being our hearings officer.
She's the best.
Well, that's good to know. We want the best in that position. So. Just to bring Commissioner Payne and Mayor Collins current, we did skip the action items down to board discussion as we didn't have a quorum at the time. So we'll move along to air quality update from Jay.
Hello, everybody hear me?
Yep, we got that.
Thank you.
Okay. Well, I'll make this pretty quick. Not a lot to report this year. Compared to last year, we're doing pretty good, but I'm going to share my screen, so please tell me if this doesn't come across. Everybody see that okay?
Yep, we sure do. Thanks.
Okay. All right, so we have one new board member, probably not familiar with this. This, at Lewis and Clark County, I'm gonna go through a PowerPoint here, just so you know, because I did send our air monitoring season quarterly report, which would go to DEQ also. Our air monitoring season basically runs through October, or starts in October through February 1st every year. And during that time, we have one monitoring station, which is located at Rossiter School. And we used to run out of two monitoring stations, the other one being at Lincoln School. The data that came from those two sampling stations more or less was identical. So DEQ decided, in an effort to save money, they would do away with the Lincoln School station. So now we're just basically at Rossiter, which is a low point in the valley. We run 3 different samplers at this station. One of them is called the BGI, which runs every 6 days. It's more or less for quality control. Our main sampler or filter is what we call a BAM filter, which stands for Beta Attenuation Monitor. It's pulling in particulates, which are what we're looking at with wood smoke and diesel exhaust, any vehicle exhaust, particulate matter, they call higher, like dust, road dust, PM 2.5, particulate matter 2.5 is our main focus, which comes from wood smoke. That sampler runs on a 24-hour basis. Every hour it updates. So if anybody's ever gone to what's called Today's Air, it's a DEQ website, or to our websites, you will see an hourly update. And bear with me here. Basically, this data runs our filters for our air pollution control district, where our regulations basically cover from the North Hills, the South Hills, more or less a Spokane.
Excuse me, Jay?
Yeah.
I'm having a hard time understanding you. I don't know if it's the way you're pointed at your microphone. I can hear
Probably.
you. I just can't understand you.
Yeah, I have a laptop that I have to talk into. So can you hear me better now?
Well, I think I can hear you better when you direct your voice to the
Sorry
microphone.
about that. I tend to talk away from it. Okay. So
Thank you.
Our air pollution control district basically is the Helena Valley. We cover the North Hills, up down to the South Hills, the Spokane Hills, and out more or less along the Birdseye Road area. We have what we call an air pollution control district regulation, or air pollution regulations, which will cover that during this time. Can you hear me okay, Candace? Again, wood smoke is identified as our main PM source of pollution, PM 2.5. Within wood smoke, you have carbon monoxide, organic gases, particulate matter, and nitrogen oxide. Okay. I think we all kind of know the health effects of wood smoke, affecting the areas of the lung. People with asthma, COPD are the worst to be affected. Typically an inversion is something that is a big concern during these months, the winter months. We get cold air settling into the valley. You know, like last week we had a cold air snap. That warm air settles down into the low parts of the valley. And then as it warms up, warm air moves in over top of it. It puts a lid on top of that cold air. And it takes a long time to flush out that cold air in the valley. But as that sits there, all that wood smoke, all that diesel exhaust, dust, all of that builds up in the valley. And I know you've all seen an inversion. It's not a pretty thing to look at. So that's when our regulations start taking effect as far as monitoring and restricting wood burning. So, like I mentioned, we are susceptible to inversions in the wintertime. Not a fun thing. Here's a picture of our sampling station out at Rossiter School. And the reason this is at Rossiter is because it is the low point of the valley. All that wood smoke from up here around the Capitol, out in the hills, it tends to settle right to that point. And here's some data. A lot of you probably saw this last year, but basically we have three monitoring episodes that we look at. We have a good, a watch, and a poor. Right now, today, we're in a good episode. Once we get to a certain level of particulates, we'll move into a watch, which basically during a watch episode, we encourage people with wood stoves to find an alternative heat source. So if you're primarily burning with wood, we recommend burning with or turning on your heater, your forced air furnace until we get out of that. That way we don't have to move to a poor episode, which we start restricting burning in certain areas because of the high particulate levels. But just to quickly touch on this, so far this year through February 14th is when this report was created. October or November, December, January, February, we had 98 good days, 4 watch days, and 4 poor days. So we're doing pretty well. If you go back to say 2017, our poor days were very high. So a lot of this has to do with temperature, and primarily most of it has to do with wind. So if we have days that are windy, it tends to flush out the valley. We can be affected by, say, the Forest Service burning up in the South Hills and so on and so forth. Depending how that wind directs it, sometimes it'll push it down in the valley, and we tend to suffer on those days. So, but so far we're doing pretty good. Only 4 poor days. Hopefully, we can make it through the end of February without any more poor days, which we're looking pretty good right now. But does anybody have any questions on this? Anybody hear me okay?
Yeah, doesn't sound like it, Jay. Thank you very much.
All right. Well,
Keep that good air coming.
yes, thank you. Have a good day.
Thank you. All right, we'll bump back up. Bump back up to the action items. To discuss a Board of Health conflict of interest policy.
Thanks, Mr. Chair, members of the board. Just for a little background and point of discussion for you all today. The Board of Health in practice does a really great job of identifying conflict of interest and then disclosing conflict of interest. I think a good example of one that we see every year is the county commissioner who sits on the Board of Health discloses a conflict of interest during the budget discussion and the budget vote, and then essentially doesn't vote along with the other board members for that purpose because the county commission ultimately sees that budget and does a final vote. So it would be, I don't know if that's a good example, but that's one of the things that we might see or that we do see every year. Other conflicts may have to do with variances that come before the board. So it's best practice to have a written policy in place for the Board of Health. And then every year go over that policy, review the policy, and then board members sign that they understand the policy. And then in practice, having a disclosure form available for board members to use when there is the need to disclose a conflict. So this was created and given to us by the Department of Public Health and Human Services. I reached out to the Systems Improvement Office up there and asked if they had an example. They didn't at the time, so they worked through their legal team at the state to come up with this conflict of interest policy for your consideration. I also ran it through our legal here at the local level. So our county attorney's office have also seen and they didn't have any suggested edits for you. So at this time, I recommend that the board have discussion about this conflict of interest policy and then vote to adopt it.
Thank you. And as I understand, there's sort of the policy on one page here and then the actual disclosure form, which kind of reiterates basically what's in the policy or kind of at least parts of the policy that are there.
Yes, yeah, the policy is on page 6 of your packet. And then the disclosure form is essentially what you would use in practice if there is the need to disclose a conflict.
Comments from any board members? Have people had a chance to review the policy? I'll take that as a yes.
It's pretty standard
It
conflict
is
of
a
interest.
yeah, it's standard practice.
No curveballs in there, I
Yeah,
promise.
certainly no attorney, but I didn't see any obvious curveball in there, so. Well, this is an action item, so I would entertain a motion to approve the conflict of interest policy and interest disclosure form.
Do you have to do- Oh, sorry. I just had a question. Do you have to do approval of the policy and then approval of the disclosure form?
No, it's all, the disclosure form is a part of the policy.
Okay.
Yeah.
Thanks for the clarification. I'm not sure if I
Move.
started. Yep, go ahead.
Can I start the motion? So
Yes,
I move that we approve the conflict of interest policy for boards of health as presented today by our staff.
Second.
do we have any additional discussion? And I don't know if there's any public comment. I didn't see any obvious public.
I don't have any.
All right, not seeing any additional comments, all in favor of the motion as presented to approve the conflict of interest policy, say aye.
Aye.
Right?
Any opposed? Sounds like it carries. Thank you.
And Mr. Chair, what we'll do is either board members can use the version that's in their packet. Or we'll put it on your board, we'll put it on, you have letterhead that belongs to the Board of Health. We'll put it on the letterhead and send it out. You can then sign it and we'll keep records of those signed policies back here in the office.
Thank you. All right, we'll move down to board training, health equity.
All right, thank you, Mr. Chair and members of the board. This is my attempt again at infusing a little bit of training into each of your board meetings. And so today's topic is health equity. And it actually builds nicely from the material that I presented last month. We talked about the 10 essential services of public health and then the foundations of public health services. And just to bring those back, those models by which public health does our work equity is at the heart of it. So whether we're talking about the foundational public health services, which are the communicable disease control actions, our chronic disease and injury prevention, maternal child health services, equity is at the heart of the work that we do in the health department. And then also those public health 10 essential services. Again, equity is right in the center of what we're expected to do as a health department and how we do our work. We're expected to keep equity kind of at the core. So starting there, and then just also talking just briefly about the everything that public health does is pretty well data driven. So we have our community health assessment that's done every 3 years. We look at a whole variety of health indicators, anything from asthma rates in our county to social determinants of health. So when I speak of social determinants of health, I'm talking about things like education and housing and income. And so we know that individuals who live in this county their health is impacted by those factors. We know that individuals who don't have access to high quality education have poor health outcomes. We know that those that do not have access to safe and stable housing have poor health outcomes. Those that don't have stable income, people of color, and people who are living with disabilities in our county have poor health outcomes. And we know this because we collect that data, we do that surveillance, we analyze the results of the data every 3 years, and we report that out to the community. But it's not enough to just know it, right? It's not enough to understand that these factors in our community have a negative impact on the people who live in this county, but it's the health department's responsibility through the 10 essential services and the foundations of public health services, the work that we do. It's imperative that we then address what we're seeing in the data, that the actions that we take move us in a direction that improves health equity and decreases health disparities. And so I have Jolene on standby, ready to queue up a video for us, which is it's a short video. It's presented by the Association of Public Health, or American Public Health Association. My goodness. APHA, American Public Health Association. And I'm using this because they do a really nice job of explaining what health equity is. So we're going to start there, and then we'll talk a little bit more about what we're doing specifically to improve health equity in our county. Go ahead, Joel.
Expert with the American Public Health Association, and today we're going to talk about health equity. Let's imagine that you're a baseball fan on your way to a game. But when you reach the stadium, there's a wooden fence blocking the view. Some people are standing on milk crates to catch a glimpse. Some are tall enough to not even need a crate, but they're standing on a whole stack of them anyway. And some are standing in a ditch where even a crate couldn't help them. So some get to see the game and some don't. We face a similar situation in public health. There are people who can easily access whatever resources and services they need, and others who struggle to get the basics, like healthcare, clean water, safe housing, education, and a livable wage, which means that certain groups of people are more at risk for disease but have less ability to get treatment. So they may be more likely to get severely sick or die from treatable and even preventable diseases. Let's go back to our baseball example to explain more. Just like a difference in height helped some people see the game, many health outcomes are a result of things we can't change, like age or genetics. Bones become more brittle as we age, so we'd expect 80-year-olds as a group to suffer more hip fractures than 30-somethings. On the other hand, back at the game, some people weren't naturally tall enough to see and didn't have any crates, and others were forced to stand in a ditch. Likewise, many gaps in health trends are caused by a lack of access to various resources and are rooted in unfairness. A person's education, income, employment status, and housing all have an impact on their health. These are what we call the social determinants of health. And when non-medical factors like these contribute to a difference in health, we call that difference a health disparity. Like Black mothers are almost 3 times more likely to die in childbirth than white mothers, and are less likely to have access to quality prenatal care. There's no biological reason for this, but there is a strong history of medical racism towards Black women. So this is an example of racial inequity, or the unfair and unequal distribution of resources along racial lines. When addressing health disparities, some focus on equality, which would mean giving the same assistance to all. But this doesn't often work in practice because some people need more support or a different kind of support than others. An online portal that lets you quickly sign up for vaccinations is a great idea, but for people who don't have internet access or a car to get to the vaccine clinic, it's still a one-size-doesn't-fit-all solution. That's why public health professionals are focusing on equity. An equity approach strives to give everyone the chance to live their healthiest possible life, but gives extra attention to those who face ill health because of a lack of access or opportunities. Like the more than 2 million people in the US who don't have access to running water or plumbing. Some of these folks have no choice but to get water through old, poorly maintained pipes, which can lead to serious infections. And the people affected by poor water quality are disproportionately communities of color, children, older adults, and low-income or rural communities. Historically, less affluent neighborhoods haven't received enough funding to fix their water infrastructure. To make sure this problem is handled equitably, APHA recommends that federal and local governments use any extra money to improve the water infrastructure in those neighborhoods. APHA also recommends that governments, schools, hospitals, and other branches of public service work together to identify and provide the specific support the communities need, so everyone can live their healthiest possible life. So that's health equity in a nutshell. A public health approach that tackles health differences which are avoidable, unnecessary, and unjust, and works to improve everyone's health. Thanks for watching. This video is a part of a series created by Complexly and the American Public Health Association to shed a little light on the important work that public health does. To learn more, visit apha.org.
Thanks, Jolene. They did, again, a much better job than I did of stumbling through that material, but having a definition of health equity really does help, especially as we continue to have conversations within our community about how do we address those health disparities and improve health equity. And so in Lewis and Clark County, there are a couple things that we are doing actively. The first is our community health improvement plan. So again, every 3 years, on the heels of a fresh new community health assessment, our community works together to create a community health improvement plan. Right now, our community health improvement plan addresses areas like behavioral health, housing, and chronic disease. And you'll notice when you look at that plan, there is a health equity thread that goes through the goals and objectives of each of those priority areas. And so really kind of prompting our community to have conversations, no matter what we're working on, having conversations about who is most impacted and how do we create a more equitable approach to the work that we're doing to improve health in our county. The other example is our strategic plan. So it was just last year that the Board of Health adopted a brand new shiny strategic plan. It was last April. The first full initiative in the strategic plan is all about improving health equity. And so some of the things that we've outlined in our strategic plan include just some real basics like staff training. Do all of our staff understand social determinants of health? Do our staff understand what it means to address health equity? And when our staff have a basic understanding, then we can start to integrate health equity approaches into the programs that we offer in the health department. And so that's another strategy, is looking for ways to integrate improving health equity into our programs. We also have outlined a strategy to advocate for health in all policies. So these are policies that are occurring within our community. So as the city and the county are looking at adopting ordinances or when they're opening a growth policy, that is an opportunity for us to participate in those conversations, make sure that those policies that are being adopted in our area have a health component to it. That as we're thinking about growth, as the video described, as we're expanding housing infrastructure in our county, are we doing it equitably? Are we ensuring that all people that live in our county have access to the services that they need? Additionally, in our strategic plan, we have a strategy to make sure that all of the education materials that come out of the health department are created in a way that reach diverse populations. As they said on the video, and then also outlined in our community health assessment, there are certain populations that are impacted by poor health more than others. And so just an example is people of color and those that are living with disabilities and those that are living in situations with lower income, they have poorer health outcomes. And so we want to make sure that with the education materials that we create within the health department, that we are reaching the populations that are at risk for poor health outcomes. We want to make sure that they are written in a way that reach those populations and that they are able to take action based on that health education. We also have a strategy to align resources to improve health equity. So that's financial resources as well as personnel within the health department. So it's really hard to do health equity work when we don't have resources to do it. And so in our strategic plan, we're committed to finding both financial and have personnel that are dedicated to helping us advance this work. And then finally, the final piece within our strategic plan has to do with continuing to collect data. We have to understand where the disparities are occurring, and the collecting data that's actionable will then allow us to put strategies around improving equity within our county. So those are some of the things that are outlined in our strategic plan that are specific to health equity. There's so much more that needs to be done, but these are small steps that we're taking. And that's essentially my approach and my recommendation is that trying to address health disparities and improve health equity, it's such a big lift. And it's something that public health can't do alone. We have to do it in collaboration with partners in the community. But let's take one small step at a time and see if we can make some progress. And then I just want to point you to a couple of key resources in your packet. So on page 18 of your board packet, there is a document that I included from the American Public Health Association, and it's entitled Creating the Healthiest Nation, Advancing Health Equity. And on the second page of that document, it lists key principles for advancing health equity. And so these were the 5 items that we took into consideration when we were working on building the strategic plan. So, there are 6 items here. So the first is being really explicit. So naming it and talking about it. So instead of dancing around it, we just need to say, health equity is important and we need to be working on it. And these are the things that we're doing. They also, APHA recommends that we identify and effectively address racism and racial implicit bias. It's really hard to reduce disparities and improve health equity without addressing racism. The third item is adopting a health in all policies approach. So again, infusing the idea of health equity into all policies that are being adopted in the community. creating an organizational-wide culture of equity. And so we're trying to do things like providing staff the necessary training and really integrating and making it just the way we do business. So building that culture. Respecting and involving communities in health equity initiatives. So this is, you all may have heard this phrase of nothing about us without us. And so making sure that as we are building programs and doing work in this community, that we're involving individuals that are impacted by those programs and that work, and hearing their voices and hearing their ideas and involving them in the finding solutions to problems that impact the people who live in this community. And then measuring and evaluating the progress, which is what we do through our community health assessment every 3 years. Continuing to look at that data, continuing to build not just generic data sets, but really specific data sets that look more deeply at the demographics that are impacted in our community. And so those are the recommendations from the American Public Health Association for us to consider, and what we used as a guide to build our most current strategic plan in that health equity initiative. And then the final resource that I put into your board packet on page 19 is from the Frameworks Institute, and it's a document entitled Talking About Health Equity. I added this because health equity can often come with as a lightning, or it's often a lightning rod for conflict. And so this document helps us to talk about it because it's important. It's important to talk about it and not shy away from it. We need to address health equity, address health disparities. But how do we do it in a way that doesn't create friction, right? How do we talk about it in a way that actually brings people together around the topic? And this particular resource recommends that we use language like fair and just. And so I won't go through it, but there are three definitions that are on that document that really help to frame health equity in a way that hopefully will help us to engage in conversation with people in our community in a way that achieves just that we're bringing people together around the idea of breaking down disparities and building up systems and processes and programs and services that allows for all people in our community to achieve their greatest health. Again, it's a public health responsibility, and we must find ways to really integrate it into the work that we do, and also promote and encourage all systems within our community to do the same. So working in partnership with the hospital, for example, or working in partnership with Pureview Health Center, for example, we are able to achieve greater health equity when we can work in partnership with one another. It's not something that public health can do alone. So there's your board training for the month. What questions can I answer, or is there discussion that you'd like to have about the topic?
From a social determinants of health data collection, do you get the data from the hospital and the health center then?
Yeah, so in the way we do have a whole variety of data sources that have been used. So in our most recent community health assessment, there's a section. There's a section called Setting Systems and Determinants of Health. And so I'll just flip to page 47 of the current assessment, which is talks about access to health. And so we were able to not only get or include data from the US Census, but also from St. Peter's Health. We also did some data collection during vaccination. It's a post-vaccination survey that we did. So we collected data from a whole variety of sources. And this year, 2024, we'll be updating the community health assessment, which gives us another opportunity to make sure that we're collecting data from across the community and that we're really painting a clear picture of what those social determinants look like in Lewis and Clark County. So in a way that they're actionable. Like, what are we going to do with that data once we collect it? Like, how are we going to use that to then address the disparities that we're seeing in that data? So.
Thanks. Yeah, I know. I'm curious to see, because the community health assessment was done 2021.
2021, yep.
Yeah, and that's right in the middle of the pandemic.
Yeah.
And curious to see if numbers increase or the data increases or access, the telehealth type stuff that occurred, when you're virtual for almost 2 years, how much that virtualness carried on and allowed for more access, I guess.
Yeah.
And then what we'll see.
Yeah,
So-
which is why it's so important that we do our community health assessment and put the report out every 3 years for that very reason, because we know that circumstances and situations change, and they often change enough to see trends change. So it will be interesting to see what comes of the report this year. It'll be out. So community health report will be out by December of 2024. So. Mayor Harris.
Yeah, thanks for the time here. I know you mentioned growth policies. Is there any other specific examples like that you would point to, specifically for a municipality that we can be working better with the Board of Health to address health inequity?
Yes, actually, I use the growth policy as an example because the county is opening the county growth policy as we speak, which gives the Board of Health and the Health Department an opportunity to review and have input. So an example of something in the growth policy is making sure that all neighborhoods have sidewalks and that they're lit. So that's an example of a health-related approach to a growth policy, and why sidewalks and lighting in neighborhoods are so important is so that people have the ability to get outside and get some exercise in a safe manner. So they're on a sidewalk out of the street and they can walk early in the morning and late at night. So that's an example. But Mayor Harris, if you're looking at something in the East Helena area, we have experts both within the health department and then also across the state that can help you review your policies and look at it through a health equity lens.
I was specifically like subdivision review.
Yeah.
For us is one I think that maybe this, obviously we have our standards, but just to look at it from that perspective, I don't think we do necessarily a very good job of.
Yes. Yeah, that is another, that's a great opportunity, is to look at your subdivision review process. And we can help you look at it through that, through a health equity lens and potentially infuse some health related aspects to your subdivision review.
Thank you.
Yeah, it's happening across the state and across the country. And we even have a couple of really good examples of things that have happened just locally. Sarah, can I put you on the spot? And do you have an example that you might share of work that's happened with kind of infusing health into local policy?
I think I'm gonna need to think about it for a second. Sorry.
No, that's fine. I did totally put you on the spot, but yeah, every time like the city opens an ordinance or adopts an ordinance, or the county opens up policies, those are all great opportunities to engage public health in reviewing those policies for health equity, opportunities to improve health equity.
There was a recent plan. Thank you, Drenda, Mr. Chair, members of the board. One of our coalitions is our Healthy Communities Coalition, which is a chronic disease prevention coalition. And one of the work groups is our Aging Well work group, really focusing on the needs of our seniors. And I'm trying to remember which plan it was, but it was one of our city plans that was just redone within the last few years. And one thing that we did is we had a few of our senior related organizations, one being AARP, look over the plan as they built it to make sure that our seniors and our aging population were really had a high focus, because just looking at, again, whatever we look at to make sure that if we're thinking of our seniors in mind, for example, then we're thinking of everybody too. So I know that they provided some feedback and got some things inserted that were helpful for our aging population too. And doing things like that will be eventually what will make us designated age-friendly community too. So that's a recent example.
Thanks, Sarah.
That's great. Any additional questions, comments?
I just have a quick comment, if I may. So I recently took a training here at the state regarding implicit bias, and I found that really interesting and sort of, thought-provoking, that we generally think of the protected classes as the obvious places where there's bias or prejudice, but there's a lot more that we don't think about. And I think to your point, Drenda, about staff training, that, we don't know what we don't know. And to quote Maya Angelou, when we know better, we do better. And so I think those are, sorts of places where the staff training can help with looking for those health disparities and finding areas for improvement. So just quick comment.
And may I just make a quick comment also?
Certainly.
I know Drenda and her team have been putting together these programs to enlighten the community, but I think I was invited to speak at that program. My wife and I, we were impressed, and I think it should be wider than just in-house, because a lot of people could learn from what we learned that day, and that will set us on a better path, so to speak. So as much as I enjoyed it, I think more people would have enjoyed it, not just the health department, but, just my 1 cent. I think you should open it up, Drenda. It's a good program.
Thank you, Mayor Collins. For board members, we have been trying to host lunch and learns every month and bring in individuals in the community with lived experience that would be willing to share their culture. And so Mayor Collins and his wife joined us this for the month of February, but we've also had a young family that were refugees from Afghanistan come in and share about their culture. That we've had guest speakers from the disability community share about their culture. Upcoming one will be the Latino culture, and what else do we have? LGBTQ, and then the behavioral health will be having a guest speaker really talk about mental illness and the culture around mental illness. So just as some examples. So thanks for the feedback, Mayor Collins. We have definitely opened it up to our neighbors here at Peerview and invited them in. But we can certainly look at ways to expand that.
Any additional comments? Any public comments on any of the items reviewed today?
We do have one, just 1 second.
Good afternoon, everyone. Officer Neiman, Mr. Chair, and members of the board. This is Mary Ann Dunwell. I'm a state senator. I represent Helena and East Helena and beyond. And I just am praising you again for the work you do. Drenda, that was a really good presentation about equities. And just as a member of the public, if you happen to open those lunch and learns open to the public, I'd be the first in line to attend. So thank you again, everybody.
Thank you. Any additional public comment? All right, I think we're adjourned. Thank you, everybody.
You know,
Have a good afternoon.
Thanks, guys.